takes into account that reticulocytes in anemic patients will stay in the circulation longer than normal reticulocytes. Now, you'll see a lot of different formulas for correcting the reticulocyte percentage. No one is better than the other. And so if you put it through this formula and your reticulocyte index is greater than 2, it suggests that you have hemorrhage or hemolysis. If the reticulocyte index is less than 2, it suggests decreased production or hypoproliferative anemia. Second question is, what is the MCV?
An MCV less than 80 femtoliters in microcytic anemia, from 80 to 100 in normocytic anemia, and more than 100 in macrocytic anemia.
Keep in mind that these are very arbitrary, well, not arbitrary, but they're not hard and fast cutoffs, that certainly there can be overlap between the groups, and don't forget that you can have mixed disorders. So someone who has vitamin B12 deficiency and iron deficiency, but their MCV is 90. And again, the peripheral smear will help with that. So the third thing is looking at the peripheral smear. And the first thing to do is confirm what you saw in the MCV. You may see large cells and small cells, but the MCV is normal. So you want to confirm that you're dealing with a normocytic, a macrocytic, or a microcytic process. The second thing is you want to look for specific findings on the peripheral smear. Things like hypersegmented neutrophils, macrothalassites, spherocytes, schistocytes, sickle cells, and we'll go into some more of that. We think about 4 basic anemias. The first is iron deficiency, which you'll see typically a serum iron that's low, a TIBC that's high, a saturation that's low, a ferritin that's low or normal. Anemia of chronic disease, you'll see a serum iron that's low, a TIBC that's normal or low, a transferrin saturation that's normal or low, and a ferritin that's normal or high. Thalassemia trait, you basically see normal iron studies. In sideroblastic anemia, you see usually high iron levels. So let's start with thalassemia. It's caused by a decreased production of alpha or beta chains. The homozygous condition is diagnosed usually in childhood, so internists rarely see a homozygous patient presenting to them. What we're going to see a lot is the heterozygous patient, the patient who has thalassemia minor, and it's common in adults of Mediterranean, African, and Asian descent. There's significant microcytosis out of proportion to what you would see with anemia of chronic disease or iron deficiency anemia. There's usually just a mild anemia. There's a high normal red blood cell count, and there's a normal RDW. All these are clues to it being a thalassemia trait. Now, what you can do is you can get the hemoglobin electrophoresis, and in beta thalassemia, you're going to see an increased hemoglobin A2 and increased hemoglobin F. Now, let's try to explain why this happens. So in beta thalassemia, what happens? You're not making enough beta chains. So you've got all these alpha chains hanging around, and the alpha chains say to themselves, well, what can I do? Where can I go? Can I pair up with somebody? And they end up pairing up with delta and gamma. And so alpha 2, delta 2 is then your hemoglobin A2, and alpha 2, gamma 2 is your hemoglobin F. So when you do a hemoglobin electrophoresis, you're going to see slightly elevated counts of hemoglobin A2 and hemoglobin F. And that's why you see that abnormality on the electrophoresis. Now, with alpha thalassemia, if you decrease the production of alpha chains, then you've got all these beta chains hanging around saying, what can I do, what can I do? The answer is, not much. Okay, there's no other chain that they can hang out with, so they kind of form tetramers and they kind of get together. And so you usually do not see much of a change on your hemoglobin electrophoresis. In fact, you may actually see a decrease in the hemoglobin A2 level, but that's not really a very common finding. If you need to diagnose alpha thalassemia, you've really got to do molecular analysis and you can make the diagnosis. Honestly, most cases of thalassemia trait are, since they probably have had it their whole lives, if you just check to see what their old hematocrits have been and follow them for a while, they probably have never changed, and so you probably don't need to work it up if you've seen this kind of pattern with the very low MCV with a very mildly decreased hematocrit. Iron deficiency, anemia, you need to search for the cause and where's the bleeding coming from. And so people would suggest doing an EGD and a colonoscopy. And really, if you look at the studies on where the money is, usually actually the money is in the EGD and not the colonoscopy. I mean, colon cancer finding for an iron deficiency patient is not as common as finding something like peptic ulcer disease, gastritis, something like that, that may be responsible for the iron deficiency. Yet, you should probably do both. The other thing that you probably need to know is that there's no proven benefit from imaging the small bowel if and idiopathic cause is unknown. And so the studies that have been done, they said, okay, we have an iron-deficient patient. We don't know where the blood loss is coming from based on examination. We do an EGD and a colonoscopy, and those really don't show us a good source of blood loss. Do we follow this up by doing a push enteroscopy and looking at the small bowel, doing a small bowel series? And in those patients that they looked at, none of them had small bowel problems that they could find. And so it's not suggested that you need to work up the small bowel to look for a site of bleeding. Again, in a completely asymptomatic patient. So anemia of chronic disease. Now this is associated with infection, inflammation, neoplasia, or CHF. This is a fairly new concept. In fact, probably not in many of your hospitals, they're probably not treating severe CHF patients with erythropoietin. And again, I think you're going to see this more and more as the years go on. Now, you distinguish anemia of chronic disease from the anemia of renal failure. Remember, anemia of renal failure, there is an absolute decrease in the erythropoietin level, whereas in anemia of chronic disease, that's not true. Most cases of anemia of chronic disease are actually not microcytic, they're normocytic, but we always group them in the microcytic category because we've done that for years and years. The mechanism includes a decrease in red cell survival, impaired erythropoietin production, but not to the level that you see in renal failure. Impaired marrow response to erythropoietin, and impaired mobilization of iron. So there's a lot of factors that are involved in anemia of chronic disease, and most of those are cytokine regulated. And the way you treat anemia of chronic disease is you treat the underlying disease. If I gave you a patient with osteomyelitis or tuberculosis, and they give you the CBC and there's an anemia there, and they give you the iron studies and everything is a little low, and the ferritin may be normal, what is the best way to treat this patient's anemia? And the answer is antibiotics. You treat the disease, and then you will treat the anemia, and the anemia will correct. Now, what's the problem with that? Well, in a lot of these conditions, like in inflammatory conditions like rheumatoid arthritis, Wegener's granulomatosis, other rheumatologic diseases, in cancers, in HIV, it doesn't work that way. You can't just treat it and the anemia gets better. So, erythropoietin has been shown to increase the hemoglobin and improve quality of life in a lot of those patients. Now, the newer thing that I talked about, in patients with congestive heart failure, you may actually see an improvement in cardiac function if you treat their anemia with erythropoietin. And again, this is not something that you're going to get tested on, but it's something to think about. There's only been a few small studies that have been done looking at erythropoietin in CHF patients with low hematocrits. Sideroblastic anemia is characterized by ring sideroblasts in the marrow and impaired heme production. So what happens when you're impairing the production of heme? Well, your body's going to say, hey, I need to make more heme and I need to get more iron. You increase the GI absorption of iron, and so you see increased iron levels and not the decreased iron levels that you see with iron deficiency anemia. The hereditary forms usually present in childhood. The acquired forms are what you usually see is myelodysplastic syndrome, refractory anemia with ring sideroblasts, and you see it with drugs like chloramphenicol, INH, and lead and ethanol. Some of these forms will respond to vitamin B6 or pyridoxine therapy. So normocytic anemia, there's a few things on the differentials. The first is aplastic anemia, again usually presenting as a pancytopenia. Red cell aplasia, anemia of renal failure, anemia of chronic disease, myelodysplastic syndrome, multiple myeloma, and thyroid disease. Aplastic anemia is characterized by pancytopenia and a hypocellular marrow. Most cases are idiopathic but can be associated with chemicals, infections like hepatitis and EBV, drugs, or radiation. Now, you support these patients with transfusions, and the treatment of choice is bone marrow transplant if you have a matched donor. If you don't, then the treatment is antithymocyte globulin and with or without cyclosporin. The thing that you need to know about aplastic anemia, that there